Good morning. And my name is Micaiah Salisbury, and I am the Consumer Empowerment Program Officer here at the New York State Health Foundation. I'd like to welcome you to our online discussion. Today's webinar will focus on strategies health systems are employing to make sharing clinical notes with patients easier and more productive. I'm joined today by Cait DesRoches, Executive Director of OpenNotes, Steve O'Neill, Social Work Manager and Behavioral Health Specialist at OpenNotes, as well as Dr. Lauren Bruckner, Children's Health Informatics Officer at Golisano Children's Hospital and URMedicine, University of Rochester Medicine. Just a couple of housekeeping things before we start. This webinar is being recorded. A recap with the link to the recording and the slides will be circulated afterwards. Video and audio are disabled for attendees, but we very much would like this to be an interactive discussion. So please type any of your questions or comments that you have into our chat box during the event, and I will read aloud those questions from the chat box for our presenters. Let's jump right in because I know that this is a topic that is incredibly relevant, given the Cures Act that recently went into effect, which grants patients access and allows them to control their medical records. Especially grateful to have Cait and Steve here, giving all of the work that they've done throughout the past years and spreading this movement to share more about what it means for healthcare systems, what it means for patients, as well as insights they've gathered in the field. And also really happy to have Lauren, who's representing Dr. Bruckner, who's representing the University of Rochester Medical Center, who's a previous grantee of ours, share her experience and the strategies that they employed for sharing notes. Cait, I will turn it to you to get us started.
Thanks, Micaiah. I am going to just talk very briefly and go over just a few things about the information blocking rule. And we practiced this ahead of time and I forgot to put my slides back to the beginning. I'm going to just talk for a few minutes about the information blocking rule so that we can then just get right on to the main event of Steve and Lauren. So I'm Cait DesRoches. I'm the director of OpenNotes. I've been in this role for over 5 years now. And we have had the good fortune of working with the New York State Health Foundation to help spread OpenNotes through New York State. And through that work also have had the wonderful experience of working with Lauren. So I think this is going to be a great discussion. Get your questions ready in the chat because these two experts here can answer almost any question you have. So first, just so who are we? OpenNotes, just to be clear, I'll start with what we're not. So we're not a vendor of any kind. We don't sell software. We don't have an app or a server full of notes somewhere that we're mining for information. We are a collection of researchers and communication specialists who are funded primarily through philanthropic grants, places like the Gordon and Betty Moore Foundation, the Commonwealth Fund, Robert Wood Johnson, and we're located at Beth Israel Deaconess Medical Center and Harvard Medical School. We have no conflicts of interest in this area. We do not take, and we have no funding from for-profit groups or anyone in the tech sector. And then what is OpenNotes? It's very simple. Again, not a software. It's just an idea that patients can easily read their clinical visit notes. As everyone on the call, I'm sure, is aware of, the 21st Century Cures Act and the information blocking rule have really directed the healthcare system to do better in sharing data between organizations, and then for our purposes today, also sharing information with patients. So the new rule, which is the implementation of the 21st Century Cures Act, includes 8 different kinds of information, 8 different kinds of notes that need to be shared as part of this new US core data for interoperability. So this began on April 5th. We have a little bit less than a month experience. Many places are now about a month into their experience with it. Although it's not a new concept, We know of at least 260 organizations that were sharing notes prior to the rule, and they were sharing notes with about 55 million Americans. So there was plenty of experience with sharing clinical notes, ambulatory clinical notes, prior to the rule. The other thing that the rule does that sometimes gets lost in our discussion of what has to be shared now with this new core data set for interoperability is the rule modernizes our access to health information, both through portals where we can now have access to many more things than we otherwise would have, but also through third-party apps. So coming over the next year and a half or so is a standardization in how EHR vendors and app developers make this information available. And I won't get into the technical details of it because it's very, very dorky. And there's a lot of technical specs there. But just to say, the 21st Century Cures Act pulls healthcare into the modern internet era. So it's an exciting time, but comes with a lot of anxiety. And I'm going to turn us over to Steve now because he is our expert in addressing one of these particular anxieties.
Great, thank you, Cait. And
you're welcome.
Well, I think what I'll start with is that, that part of the premise for those that are listening, a lot of times people get very nervous about opening up notes for patients, and they get nervous on the medical side, and they especially get nervous on the mental health side. It's also true in pediatrics that there's a lot there as well, that, there's a lot of nerve fraying aspects. And I will say just right from the get-go that in fact, actually, this has really gone well over the years that we have been doing this. So my role at Beth Israel Deaconess Medical Center is I was overseeing all the behavioral health, mental health practices for the hospital, but I'm also there as a bioethicist as well. And in my role there as a bioethicist, we began to share all of our bioethics consult notes directly with patients and including any involved family members and significant others involved in a consult, which is oftentimes very highly intractable conflicts, potentially with litigious situations. We began to share our notes directly with patients and families, and we found that it really helped tremendously in bridging the divide because families felt like we weren't trying to ambush them or hide things from them in a way. And learning from that experience, as well as in my own mental health practice, I began to share my notes with patients over 30 years ago. Myself and one of my colleagues, we just started as a practice saying to all of our mental health patients that we would open up our notes to them anytime they wanted to see them. Now, this is prior to patients having access electronically in that way, but I would print out the note and share that with them. And that helped a little bit our staff when I decided on overseeing all the staff that we would open up all of our mental health notes 7 years ago now. So it's right at this time, a little over that, we opened up all of our mental health notes. We started with 440 patients, and we now have well over 5,000 patients that have been in the OpenNotes program at Beth Israel Deaconess. And that, in fact, we've had no untoward outcomes. We've all anticipated it. We all got nervous about it. All my staff got nervous, but they knew from some of the experience that several of us had had that in fact actually had gone very well. And even our legal department, who had been very nervous about us opening up notes in bioethics and didn't want us to do that initially, they found that we cut down on phone traffic to the legal department by better than 50%. And we really bridged the divide, and they really viewed that we headed off a lot of risk management situations. More importantly, from my perspective, is I felt like we were delivering better care to patients because we had better partnerships with them. So when we opened up our notes in 2014 on the mental health side, the medical side had opened up in 2010 in primary care, and all the specialty services at the hospital began to open up in 2013. And we held back in psychiatry and in mental health, but then we opened them up in 2014. What we found was that it really decreased the stigma for patients. Many of our staff were all worried that you know, patients can't handle it. They're going to decompensate. They're going to get worse. We're going to do things that'll be harmful. And we found that, in fact, actually, we had just the opposite effect. It really settled things down, and particularly when patients could see concordance between what we wrote on our note and what we had said in the visit. So when there's concordance between those two, that's true in the medical side and it's true on the mental health side. And we've replicated this in some of our research studies as well, not just at Beth Israel, but around the country. That's oftentimes what patients worry about. I mean, what I heard from my own panel of patients is they always wondered, what did I really say about them behind their backs when I was writing a note? Did I really say the same things that I said in the office? So if they can see concordance, it helps them to engage in the care better, and it just moves things along. And I think with the Cures Act, just opening it up, that just makes this a very rich opportunity for us to really partner with patients. From a bioethics perspective, the way to think about the Cures Act is that we're moving from a position of really overt paternalism, where we providers decided what was best for patients, and we're moving to a position of patient autonomy. But it's not what I think of as undue patient autonomy. We don't want to swing the pendulum to such an extent that patients decide everything, where we would lose our ability as professionals to maintain our professional integrity and our professional autonomy. So we have to have a balance there that recognizes that we have standards that we have to meet as well. So our notes have to communicate to the insurance company that's paying the bill, or our cross-coverage colleagues, or the emergency department, or whoever it might be. We have things that we have to maintain that are in our purview, but we also want to make sure that patients are informed about their life and their body and their health, and that they can engage more. So that's been the experience that we've had, and I'll stop there. So.
And then I think I'm up next. Hi, I'm Lauren Bruckner, and just to full disclosure, I'm a pediatric oncologist, so I treat children with cancer, and I'm also our medical director of patient engagement across our URMedicine enterprise. So I oversee the patient portal, which is where this really why I got involved in OpenNotes, because we probably now about 5 years ago, started to share some notes. And then with the New York State Health Foundation and OpenNotes Collaborative, we did a community-wide launch in January of 2019, where we partnered with our competitor here in Rochester, and we all went live on OpenNotes at the same time. What I will share is that that experience was very different than what's now happening with the Cures Act. So then it was purely voluntary that we were doing it. And I'd say that the biggest thing we found as I was going out and preparing folks for this, the biggest questions I would get was around the why. Why do we need to share our notes? What value of it is it? Do my patients even really want this? And a lot of providers actually were concerned that this was going to hurt their patients. So they had, I would agree with the word that Steve used, of paternalistic. They were worried this was going to actually cause harm. So it was coming from a good place, but it was rather paternalistic. And so they had all these concerns. So a lot of whys. Why now? Why is this coming? Why the push for this? So a lot of education had to be done. And it was a lot of culture change of trying to get people to understand that patients really do like this. So we wound up having to do it in kind of a phased approach, where we did a pilot and did surveys, both of our providers as well as our patients. And I'm sure to nobody's surprise on this call, patients loved it. They were I think we had something like 1,500 patients, or definitely over 1,000 patients who in a short period of time that we sent the survey out responded very quickly, all very, very positively, with little negative downside to it. One of the big provider concerns was also around just the impact it would have on them, on their own workload, that this was going to cause more questions and confusion among their patients. None of that panned out in any of our studies that we did. And that was both in surveys as well as actually going into the medical record and looking at keystrokes and how many hours patients or doctors, providers were spending in the electronic medical record. So we have collected all the data, and we're not the only ones who did this across the board, across the nation. When it has been looked at, that's been sort of the takeaway, which is lots of concerns up front, but when you actually implement and actually rip off the Band-Aid and start sharing, I've actually had providers say, am I definitely sharing my notes? Are you sure my notes are being shared? Because the impact that they feel as providers is not what they were expecting or most afraid of. But that was before. So before, when it was voluntary, it was why. With Cures Act and the information blocking regulations, it's now been much more there's a big why. The why is because we're going to be fined if we don't do it. And so it very quickly shifted to a, well, how? Can you help me? Can you help me? How do I write a good note if it's going to be shared? How do I prevent certain parts of the note that really shouldn't be shared, that the patient doesn't want me to share? You know, how do I use the tools in our electronic medical record to not share when I don't want to? Or, you know, when it's appropriate. And can you help educate me? You know, how do I know when it's okay to share and when it's not okay to share based on these regulations? So, and then there was one more, using all the tools and helping. Oh, and the whatabouts. There are a lot of unique situations where it is difficult. It's difficult to marry, if you will, between the regulations and the wanting to share and needing to share information, but of those times when it really is inappropriate. So there are exceptions within the info blocking rules and what I would call really reasonable reasons not to share a note at times, and figuring out how to identify those appropriately can be tough. And so we went through a lot of, what about in this circumstance? What about in that circumstance? And the type of circumstances I'm talking about around, remember too, there's two types of sharing we're talking about. They're sharing with the patient, and then they're sharing with the patient's proxy or somebody else who has access to the patient's portal. Sometimes our tools, our technology tools haven't quite caught up to what our needs are because of this increased sharing. And so we have sort of hammers when really what we need are scalpels. And so sometimes we can't separate what's shared with the patient from what's shared with the proxy in a way that I think makes sense, and I'm sure will be coming in the future, but right now our tools are limited. And so it leaves a lot of the onus on the provider to talk to the patient and say, is this your preference? If I share this, your proxy is going to see it too. What do you want to do? So it adds a bit more communication, which I think is a good communication to have, but something I don't think most providers were thinking about before. And so many of those types of things, whether it's around issues with confidentiality. So for example, we have maternal information that might be in an infant's chart. Is it okay for that maternal information to also be shared with the father of the baby if the mother did not want to? There's all these kinds of unique areas where we've had to put a lot of extra thought into what we're doing. The biggie, as a, again, pediatric person, not only maternal issues, but adolescents. Adolescents are particularly difficult because of all of the unique confidentiality things around dealing with adolescent healthcare. And you want to provide them the ability that the adolescent themselves should have some autonomy on that, but the relationship with their parent is controlling, and the parent usually has access to all of their records. And so it's a very difficult circumstance to figure out how to best share when it should be shared, but not when it shouldn't be, and not allow the parent to see information the adolescent didn't want shared, particularly in New York State, where we have actual regulations, laws about inappropriately sharing confidential information around adolescents, particularly around reproductive health. So I think that's where I'll stop and just say that it's a good thing. I think a lot of positives have come from this, but that there's still, I think, a lot that we're trying to do to balance between really making it easy to do the right thing when sharing is the right, it really is appropriate not to share. And that's still difficult right now. And I'm hoping technology is going to help us very soon.
Great. Well, thank you, Cait, Steve, and Lauren. I'd like to move on to the question and answer portion of our session. Just a reminder, if you have a question, please submit it in the chat box, and I will pose those questions to our panelists. My first couple of questions are for you, Lauren. So you spoke a bit about the physicians initially being reticent about sharing their clinical notes and that maybe some of those concerns weren't realized once you actually implemented OpenNotes. Have you heard from any physicians of the benefits that they've seen from actually sharing their notes with patients? And what has your personal experience been with sharing notes with patients?
So I'll start with my personal experience. I was one of those folks who have always, when I'm writing a note in clinic, have always turned my computer and written the note with the family. So there was very little difference to me of sharing the note because they helped me write it. So they had seen it all. And if anything, it was helpful because there would be things in my note from the last time that that helped the family, and they came in the next time saying, well, because your note said such and such, I remembered to go get that done. So, but most of the time, I'd say 90+% of the time, it didn't have a significant impact to the way I was already practicing. I did have one of my favorite stories is one of the person who at the time was the head of our cancer center, who was not a proponent of sharing notes in the beginning. He was one of the biggest, he had the most concerns about sharing, particularly oncology notes. And he came to me several years after sharing for a while and said he could totally tell the difference that his families were and patients were coming to their appointments much better educated around the things they had talked about the last time because they had been able to show it to their family members and reread it and think about it when they had more time on their own. So he himself, without prompting, became one of my biggest advocates when I would be going around and talking elsewhere about OpenNotes because he noticed a real significant change in just the preparedness of his own patients, how engaged his own patients were.
It's wonderful. And then aside from kind of getting physician, staff buy-in when you're about to roll them out, were there any particular challenges or any ongoing or new challenges that you've kind of had to face as you've implemented the note sharing?
I think yes. The answer is yes. It's not easy. It's a big change, and not just for providers and on the healthcare systems, but for patients and families themselves, right? This is a new to everybody kind of thing. And even though much good can come of it, it's still a change, and change can be hard. And so communicating the change is probably what was the most challenging. I would say when we went through this process with OpenNotes and New York Health Foundation, the brunt of what we spent our time really doing was communication. It was around education and communication and trying to get the message out in every way we could think of doing over the period of time we were preparing to go live with the sharing of notes, just to make everyone aware that why we were doing that, it was happening, and why it was happening, and what to expect. Yet I was still amazed because I felt like it was just again and again and again and again, all the same stuff that was being said about this. But at the point that we actually went live, a bunch of people were like, what is this? I didn't know we were going live with this. And it's just such a struggle to get the message out. So that's probably the biggest takeaway is no matter how hard you try to make sure everybody is aware that a change is coming, there are going to be people who didn't read the email, didn't see the posters everywhere, didn't see the screensavers, and the things all of those types of things that we tried to raise awareness about, including lots of, going to conferences and open houses and everything we could think of to try to make sure people were aware of this. Some still aren't aware. And I think when people aren't aware is where there's the most resistance because it caught them by surprise. So the family who didn't realize notes were being shared and then read something that, or, didn't say don't share it and something went to a family member they didn't want shared, that kind of thing.
Great, thank you. My next question from one of our participants is, and this could be answered by any one of you or all of you. So the question is, can you explain what and how we have to share? What does quote unquote going live mean?
I can start that and then others can jump in. So the information blocking rule directs what they term as actors, and actors in this case means healthcare organizations, EHR vendors, and others, to share this core set of information. And you can look on the ONC website, and actually I could pull up a graphic if we want to do that later. But it's a set of information about that's in the patient's record. And it has to, if you are maintaining it electronically, you have to share it with patients electronically. So if you're maintaining it in Epic or Cerner or some other, if you use an electronic health record, then you have to make this information available to patients electronically. And some places are doing that through their portal. They're just proactively sending the information to the portal because there's language in there that says this information has to be available without delay. So they're just sending it to the portal. And then others are using more of a hybrid approach where they're sending anything from their go live date forward is viewable in the portal, but things that are that are prior to that go live date, they're using their view, transmit, and download function in the portal where patients can go in and request.
Yeah, I mean, I think very quickly put, or simply put, flipping the switch to say I'm going to start sharing all notes across my enterprise is actually easy. Like going in and technically making the change and saying, today we weren't sharing it, tomorrow automatically all the notes are going to be shared is an easy technical switch. It's the change management piece of it that's much, much, much more difficult, preparing people for that change. And so that's the lead up to the day that you actually flip the switch. And now from that day forward, anytime a provider finishes their note and finalizes it by signing it, the note is automatically also available for the patient to see in their patient portal. That's what we mean by go live. Does that answer that question?
I just happened to notice a follow-up question in the chat about what if we don't have a portal? So if you don't have a portal, you still have to make the information available to patients electronically, either through some other means. You could give it to them on a thumb drive, but it has to be made available to them electronically. There is this sort of content and manner exception, but the way that I have heard meaning you don't have to provide it if you can't provide it in the way the patient asks for it. But I recently heard someone from ONC describe that as, think like you had a natural disaster. And so it's a pretty narrowly defined exception.
So, and let me chime in there too, just in terms of there's the content and manner exception that Cait just mentioned, but there's also the exception that if there's a potential harm to the patient or a privacy exception. But what's really important about the harm exception is that the way that it was carved out and written is that it is for physical harm to the patient, right? Now, what does that mean? So it doesn't mean if the patient's going to get upset, emotionally upset or distraught, that's not physical harm. If they potentially get suicidal or they have an eating disorder where in fact actually seeing their weight might in fact actually tip them to do harmful things to their body or themselves, then you might be able to invoke the harm exception in that way. And then the other exception, the privacy exception, if you think of what Dr. Bruckner was mentioning before, when an adolescent is talking to someone, if there's an expectation of privacy that the parent or proxy would not see information about their note, because we know will have a chilling effect upon that adolescent talking to their provider, whether it's on the medical side or the mental health side. They're not going to talk about issues if they think mom or dad or some proxy is going to see the information. And so there is a privacy exception that allows those folks to be blocked in that way. The adolescent would still have access to the note or should have access to the note, and systems have to figure that out. And then they have to figure out if there's an exception to that. So in Dr. Bruckner's world, for instance, in oncology, and I can certainly speak to this with two of my children are cancer survivors. They're well now, but I remember when our daughter was first diagnosed with leukemia, that I couldn't hear any of the conversations that people had with my wife and I for the first 4 or 5 conversations. I couldn't hear a thing. And I remember thinking years, like, a long time later, that it would have been so helpful to know the notes and see what people, because I couldn't remember a thing. And I have been teaching informed consent at the medical school for
Yeah,
40
we talk about that. I always say up front with a new diagnosis, I say, if you remember 5% of what I'm talking about right now, you're doing really well. So we repeat it multiple times, but you're absolutely right. Written information is incredibly valuable to go back to later, to show to others, people that might not have English as their primary language, to be able to see it in writing might, help with understanding. So yeah, there's great benefit to seeing it in the written form. I agree. And that idea of segmenting, what I was telling our providers is, basically, if you're at the point in a visit where you're asking the family to leave the room because you're having a private conversation, whether it's with a teenager or whatever, when you do that, I'm asking you to leave the room now, and from here forward is going to be private. At that point, you need a separate note that's going to be not shared, right? That information is private. It's not to go to the parent who's the proxy. It's only for you, between you and the patient. So it's that same concept of segmenting what is appropriate to share versus what is not appropriate to share, which sometimes can be challenging. But I see there's other questions here, so I don't want to make sure we have time.
Sure. So the next question is for Steve, and anyone, of course, can chime in. But Steve, someone asked if you could elaborate on what you meant by the rules don't apply to psychotherapy counseling notes.
So the rules actually, they do, in my mind, they do apply to psychotherapy notes in that way. But what they're really referring to, is my understanding, has been for a lot of us that practice, we keep side notes. We kind of keep process notes, those kinds of things. And those are side notes, can be segmented in that way. But what I put in the record, for instance, all my notes in my record or all my staff's notes, they go in the medical record, and that has to be shared with the patient. Right. And then unless it fits one of these exceptions, right, in one of these exceptional areas, for instance, and you can't block notes because there's a group of patients that might in fact be harmed by that. So I'll give you the example: domestic violence. So we see a lot of folks with domestic violence issues, and if the perpetrator of the abuse might strong arm the individual in seeing the note, then in fact, actually, we would use that as a harm exception and hold that note back. But you can't say, we're going to hold this back from all domestic violence patients. We have to do it on a case-by-case basis, even if so we can say, well, if I'm treating somebody that's a domestic violence victim, and but their perpetrator is no longer in the picture, they're deceased or gone or whatever, but then maybe I should not be blocking that person. They could have their note and it might be beneficial to them, right? As opposed to someone where it might be in more immediate danger in that way. So we have to do it, but it's on a case-by-case basis. And the psychotherapy notes are kind of those side notes that sometimes a lot of us keep, particularly if you're doing psychodynamic or a psychoanalytic therapy. For a lot of us, and I do psychodynamic therapy as well as cognitive behavioral approaches, and that's what our staff are trained in, that if you're doing a side note where you're doing process things, those are side notes and those are exempt from those rules. But the notes that are in the record electronically, they have to be shared. They can't be held back. That's been my understanding in that way.
Great, thank you. We have a question asking if anyone has experience sharing notes for patients that have virtual visits. So is it more difficult to share notes within telehealth?
No, it's exactly the same, because it's ultimately just whatever note is landing in your medical record is now going to be automatically shared. And remember, I'm not doing anything to share it. I have to actually, the only time I take action is if I don't want the note shared. If there's a specific reason with this particular patient on this particular, whether it's an face-to-face encounter or a video visit encounter, that for this particular one, I have a good reason not to share it. And I actually have to, when I say don't share the note and I take that action, I have to give a reason for why I didn't take it. And it has to meet the one of those exceptions that's allowed as part of the information blocking. So it can't just be because I felt like it this time. I mean, there needs to be a justification that fits within the framework that's been set by the OMC.
I would add too that the big concern about telehealth, if you think of prior to the pandemic, I know for my staff, I had been trying to get us to have telehealth visits and been working on some legislative side too on that for a number of years to try to get some changes in that to allow for telehealth for our patients who are oftentimes hard to reach, that they, we make it so patients have to come to us for visits usually. And so I always thought that telehealth would be a way to bring the visits to the patient. And it wasn't until the pandemic where we all had to pivot rapidly to just doing that. But it's really about the staff were always resistant because they felt it would adversely affect their ability to form a relationship with the patient. And that's kind of what the nature of this is. And so one way to think of it is that having the note to share strengthens the relationship. Again, when patients see the concordance and they can clarify things, they don't have to call back to the office for clarifying questions and all kinds of things. It really heads things off at the pass in that way. So it really strengthens the alliance, the treatment alliance, whether it's on the medical or a mental health side, either one.
Great. Another question for you, Steve. What are the rules and recommendations on sharing notes for, or I guess any of you, for substance use disorder? So what sort of precautions should be taken in regarding to confidentiality?
So yeah, usually folks that are asking that, there's a higher bar for confidentiality that, and I'll speak, having a legal background as well, that the higher bar for confidentiality applies to substance use, sexually transmitted diseases, those areas, and reproductive health are some of the areas. And so there are some areas that are carved out with a higher bar for exceptions for confidentiality that are expected. And so, but with that, I would say there's no change in the substance use questions or the documentation. We have not had to do that. And I know years ago, I cut my teeth working in the field of alcoholism and substance use when I first started working in human services, and ran a detox unit as well. And that if anything, we learned from the self-help programs that being open and transparent and honest are really the precursors for knowing that you can head towards recovery. They're the things that really help the most. From AA and NA and all those programs espouse transparency. And what most clinicians are actually more worried about is, what if my patient disagrees with my diagnostic formulation? So I think the patient has a substance use issues, they've got a problem. The patient does not. And what we generally do, and I would say this for any disagreement about diagnosis, I talk with my patients about what I'm going to document, and I put down what they believe. If they believe they don't have an issue, that's what I write. And I use a lot of quotes, and that's what I put down. But then I put down my perspective, which may differ. Again, if it's with a psychotic patient who doesn't think they're psychotic, or a substance using patient that doesn't think they have an issue, I write down their perspective and then I write down mine. And usually, again, that transparency helps. I'm not blind. And the patients just don't want to be ambushed that I've written something about them that I haven't talked with them about. So I would say be open and don't hold it back.
So just a follow-up question to that. If a patient does disagree with something, are patients able to input their opinion into their own notes? That's a question. And what happens if a patient finds an error?
So all of us could probably hit on this one. Yeah. I was going to say,
yeah.
I think the short answer is really that each medical center is going to have a different way of handling patient found discrepancies or concerns with the note. We have a formal process that starting with, if you see a mistake in the note and you write to your, make a message in the portal to your doctor and the doctor agrees, the doctor just makes the change. That's easy. But if it's one of those ones where the doctor says, no, I think this note is right the way it is, and the patient still disagrees, they have a legal right to make a formal request for a review of that and to have it be voiced and have their opinion put in there as well. So there are formal processes that I think each organization handles a little differently. But you're getting to, and I'm looking over at Cait, she can't tell, but the idea of patients themselves being able to put in notes is a whole nother next level of where I think this is going.
Yeah, thanks, Lauren. We have actually been testing out a project, an idea where patients are invited to write the subjective portion of the note before a visit. So how have they been? What brings them to the visit that day? So we've been working on that. And And we've been working on some other sort of post-visit feedback loop ideas where patients are invited to review the note after a visit and to note any issues or problems with follow-up care or issues with the note, to try to get at that space in between visits and to use the note almost as a visit extender. Because we know patients actually can and do find errors in the notes. And from our data, it also looks like they're pretty good at knowing when an error is something that really needs to be fixed versus when it's something that is not such a big deal and it can wait until the next time they see the doctor. So we're thinking, I think as we move forward, what we would love to see is the note become a way to both help patients remember what they're supposed to do, follow the follow-up care plan, but also participate in that next visit planning and use it as a way to almost extend the visit. So we have big plans.
There's also one of the things is that there was a study that was done that showed that 25% of primary care providers found that patients reported to them 25% reported material errors, and that's from the physician's perspective. They viewed it as material. We're not talking about a trivial thing, right? That kind of thing.
Yeah.
But a significant change. And so in fact, actually having patients see what's in there really engages them more, and they catch stuff that really could be problematic. So in some ways, and that's a little embarrassing for us sometimes. So we have to acknowledge that we mess up. And so it's kind of there's an embarrassment factor for providers that they don't want to have patients see stuff if they've messed up. Or for my staff, I found my staff they started doing their notes much more efficiently and on time. And as a manager, in fact, actually, there were always problems with a few of my staff getting them done on time. They felt the shame factor of not wanting to be embarrassed by their patient asking, how come my note isn't in there for me to see? That it was really helpful for them to do that. So they catch stuff. They catch stuff, and it's really important to see that. I would add one other thing just about when Cait mentioned at the beginning that 260 organizations with 55 million patients had started an OpenNotes prior to the Cures Act. 25% of them had also opened up mental health notes. So that's 25% of those across the country. And if you think of the fact that everyone's worried about this stuff, it has been remarkably quiet, a real non-event across the country. If there were issues popping up, we would have been hearing about it a long time ago.
There's a question asking about the time frame for when labs or path reports need to be accessible to patients. So should we be concerned that patients might see test results before they're able to speak to their healthcare provider?
I answered that. I wrote back and answered that, but it is also immediate release of those. Again, at a system level, it has to be immediate release of all of that any result, but with very rare exceptions, again, that meet those very specific exceptions allowable at by ONC. But on a case-by-case basis, many of the electronic health records now have an ability where, as I'm ordering that particular result, so I'm placing the order, if the patient had said, I don't want to receive that ahead of time, I want to wait till you get that result, doc, and call me and let's talk about it. And so in oncology, as I'm about to order a repeat CT scan and we think there might be a high likelihood the patient has recurred, I would say to them, as I'm ordering it, do you want to see this real time with me, that you'll probably get this result even before I've had a chance to see it yet? Or would you rather wait until I see the result first and I call you? So at a case-by-case basis, I have the ability to say, prevent the auto release for this particular patient, for this particular result, this time.
Okay. Thank you.
Yeah, it's a cultural change of really resetting expectations with patients and really working with them because, as Lauren was just saying, some patients really want to get that information ahead of time, and some really would prefer not. And you've got to, so it's a cultural change with us working more directly with our patients and figuring out what is best for them, for this particular patient.
And how are patients notified that they have the right to access their clinical notes?
That's a great question. I can tell you from our experience of trying to spread the practice of sharing notes prior to the rule, there is just wide variability in what organizations do to make patients aware that this stuff is available. So some places that we've worked with, they do a great job. They message, they send hard copy letters, they have stuff in the waiting rooms, and others don't want to do anything at all. They don't really, they feel like that would be for all of the reasons Lauren discussed earlier about the culture change that's required around sharing notes. They just were not prepared to do that. So the information blocking rule, I think, is going to follow a very similar path. That there'll be organizations that will let patients know this is coming, you're going to see this, and there will be others that will not, because they may not be ready for patients to really know yet. There is no sort of national effort to educate us, patients, consumers, about this.
And I think to that point, if one is using a portal as a way of doing this, when you sign up for the portal, you're given all the list of things that you are now going to be seeing in the portal, and notes will just be among one of those things. So going forward, it'll be, as you're signing up for the portal, you'll see all of the functionality, all the types of things that are available, of which notes is just one. And we forgot to mention this US CDI data set, which just went live in November of 2022. There's going to be an even more a more broad data set. So pretty much by then, everything's going to be shared be required to be shared in a digital form. So whether through a portal or through the other means, as Cait was talking about earlier.
So let me also add, on the mental health side, one of the things that was that we discovered in some of our studies that we've done on the mental health of the effect on both patients and providers was that, and I didn't publish this in the articles that we've written about it, but is that patients didn't bring it up with their treaters, and treaters didn't bring it up with their patients. They both were quiet, and that fits the mental health realm, where we're always waiting for the patient to bring up something, right? So we kind of do that. So we were all waiting, and the patients were all waiting for the therapist to bring it up. So it was one of the things we've been encouraging clinicians to just bring it up. Have you read your note? And, are you reading your note? And what did you make of it and stuff? And just to ask directly about that and have that become a tool within the therapy. Again, within mental health, it's helpful for most. And there could be a couple that, I've had a few patients that they didn't want to read it initially, like obsessive compulsive patients were afraid that they might ruminate too much and fixate on certain words or whatever. So they held back on reading that for a while. And so you get certain ways where it's a tool in your toolkit, and it's going to be, something where some of my patients printed out every note because they couldn't remember things from session to session or what we talked about or what their goals were. So they had to print it out, and that was really helpful as a little bit of a transitional object in that way. So there's a lot of ways in which it can be really helpful, but we need to be a little bit more active, the clinicians do, with our patients in that regard.
Exactly, which is why I think the training for clinicians is important in proactively having those conversations with patients. Can you all talk a little bit about the clinical notes that we're referring to, and as opposed to the coded values that may appear in a patient's bill or clinical discharge summaries within a patient portal, and how do we ensure patients understand all this information?
Well, what has to be, sharing the note, that's just the words that the clinician writes. So even though we know the notes are used for billing and other purposes, what goes to the portal for the patient to see is just that, what the clinician wrote. As for helping patients process the information that's in there, our work that we've done has been really interesting in this regard, in that patients turn out to be very resourceful in figuring things out. If they don't understand it, they may have a family member who can help them. They may have a nurse that lives down the street. People sort of use their resources to figure out what's in the note. And what we found in our surveys is that when we ask about the benefits of note reading, so how important is reading your notes for engaging in your care, feeling in control, taking your medications as prescribed, patients who have who speak a primary language other than English, patients who have lower levels of formal education, they're more likely to report these benefits. And it's a little bit counterintuitive, but I have heard from people who speak English as a second language saying things like, well, in the visit, I am translating and back translating everything as we're talking. And that makes it really hard for me to remember what we talked about. So when I can go home, and even if it takes me a little while to puzzle through the language, it's a great tool for me to be able to remember what we talked about.
So I would add one other thing. I think embedded in that question, it's a good question, is that that clinicians are obligated to put down certain language that meets the criteria for ICD-10, and diagnostic billing. And so for instance, as an example, the term obesity or morbid obesity, for physicians and nurses will put that down routinely in a note for someone where it might apply to that. And yet patients, oftentimes, they've never had a discussion with the patient about that term. And, obviously the person knows I'm a large person, right, or whatever, but they haven't used that term. And what we've found is that the patients have to, what we have to do is educate our patients that in fact, actually, it's a very pejorative term. And I wish they would change the language around it in some way, but it also is necessary for billing. And this is kind of an artifact of billing. If it's not put in there, you don't get reimbursed for the visit with that. So that's a real problem. There's a lot of things like that point to the fact that the clinical note also has to have certain language that is necessary for the billing. And that can be, we have to prepare our patients for those kinds of things too.
And not just the patients, but the clinicians writing the note, because that was one of the big pushbacks. People said, am I supposed to be writing this note now for the patient? Change the whole way I'm doing it? And no, we would educate, no, the main purpose of the note is still as it's always been. It's a clinical communication tool between clinicians and providers and, meant for the medical record. However, we're letting patients see it. So you have to imagine, this is how I always tell people, just imagine the patient is looking over your shoulder as you're writing the note. Don't put things in that you either haven't talked to them about or potentially abbreviations that could be easily misconstrued. Like my favorite is SOB, which in medical jargon is shortness of breath. We use it all the time, SOB. Patients might not, see SOB and be thinking something very different. So we did put in abbreviations for patients, like in our MyChart in our patient portal, so that they can go look up some of those abbreviations, because we do use a lot of jargon, right? It's part of how we communicate as providers and clinicians, but allowing an easy access to a dictionary of those abbreviations makes understanding the notes much better. But again, the goal is not to write the note to the patient. It's still that we're letting the patient see the note we've written about them. Does that make sense?
I just wanted to add one more point to what Lauren was saying. Clinicians do worry, I'm going to have to change the way I write my notes. But we could think about ways that could be a positive change. So, for example, we know that bias can be transmitted in notes. The way that patients are referred to, the things that clinicians put in a note can both be offensive to a patient, but also transmit bias to the next clinician. So the next clinician reads that note and already has a picture in mind of that patient before they even walk in the door. So the changes in the notes, while change is always frightening and anxiety producing, could also have some very positive benefits.
Thank you. Are you aware if the sharing of notes will be something that accrediting bodies will be looking for, assessing organizations?
Yeah.
I don't know about for accreditation, but there are fines. If you are not sharing notes, ONC will fine you, or it's not ONC, the body
CMS.
It's going to be, so there will be fines for organizations or individual providers or entities that are supposed to be sharing information and are not, and so are in what's the technical, Steve, what's the legal term when you're not in compliance with
Non-compliant.
when you're not in compliance with the information blocking regulations, there are fines, and they're not small fines.
Yeah, but we don't even have measures of how transparent an organization is. So the accrediting bodies are not looking at this as a quality metric or a performance metric. But if you are reported to ONC by a patient as you are information blocking, and ONC, and maybe you're a repeat offender, or ONC looks into that complaint and decides, yes, you actually are blocking information, you can be fined.
Yeah, I would also add that I'm sure that when CMS comes for site visits for certification for an accreditation for the various institutions, they will have this on their radar to see how institutions are doing with it. I mean, that's very easily predictable that going forward in the future, that'll be one of the things that we will have to be attending to.
Great. We have 2 more minutes. So just my final question for the 3 of you, is there one last takeaway that you would want to share with organizations that are kind of recently embarking on this journey?
I have one. We will not. So reading notes has a lot of benefit. Patients experience a lot of benefits when they read them. We won't get to the benefits as a healthcare system until patients are actually engaging in the notes. If we never get there, then all we've done is create a lot of angst for a lot of providers, and we never get to the benefits. So I would encourage clinicians and organizations to talk to your patients about this, to get them looking at their information, because they'll be better prepared, they'll be able to engage, and they'll remember what they're supposed to do, and you will see the benefits of it.
And I would add my 2 cents is that I think that in fact, actually these efforts really decrease the stigma that we have with a lot of patients, particularly in the mental health side, that when we think our mental health patients can't handle it, when in fact, actually, we've got studies, very good studies, and all of which are on our website, on the OpenNotes website, is there as purely as a public service for a mental health toolkit and literature and the research and all the findings we have that's there, that it really helps with patient engagement and trust. And that's true across the board in mental health and in medical. And I think it's a way to partner with patients. And I think it allows us to give better care.
And it can be done for 0 cost. It's free and without any extra effort by the provider. Literally, it's just automated and should be able to be done. You can reach all those patient engagement, good outcomes with no work or cost. What other things can you say that about? So this is a good thing. It's really a good thing.
Well, I think we have a ton of resources that were sent via the chat, but we can also send some in our follow-up. And see, there was a request if we could share the study of the primary care physicians where the patients noted material errors. If we can share that as well as a follow-up would be great. I'd like to thank Cait, Steve, and Dr. Bruckner for sharing their insights with us today, and especially thank all of you for joining us in this webinar. As a reminder, the recording and the slides will be sent out after this. Be sure to follow us on Twitter at NYS_health, or go to our website and sign up for our e-newsletters to learn more about our upcoming webinars and resources. Have a wonderful rest of your day, everyone.